our Q&A session today. We've got Professor Jones with us today. Just a little bit of housekeeping before we get started. Just remember that these Q&As don't take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So because of that, we'll often generalise the questions that have been sent in. And if you need some more detailed support, please contact us on the helpline. As I mentioned, I'm recording the session here within ClickMeeting, and I'll upload that to our YouTube channel. But please be assured that the right-hand panel here that the people in the room can see along with us, that has and names of the person that's in the room and also the comments, that's not recorded. So that's a private space whilst we're in the room here in the Q&A. So I'll get started on the questions that we've had sent in. If you've got any questions for us live, pop them in the chat and I'll keep an eye for that as well. I've actually slightly swapped the order of the questions that I sent to you, Professor, because I decided that there was one that I really liked and I thought we could make a general mini from it, which would be great from a resource perspective. So The question is, what I'm looking for is information on the gold standard testing for PBC, the gold standard care for PBC patients, and additionally, the typical sorts of care and subsequent follow-up tests, either yearly or 6 monthly. And I just thought that would be good from a general chat about what to expect. And I also did a bit Blue Peter and got some resources out ready to
Have you got an URSO dose calculator to hand as well?
I don't have that I don't have that to hand. Call out. No, I don't.
Okay, so very good question. It's the heart of what we do and also very topical because I think there's been some evolutions. So what I'll do is I'll give you what I think is a sensible view, and this is these are things that should be available everywhere. Okay, so I'm not going to suggest that it's some test that's only available in 2 centres in the world. One of the things about PBC is the testing that you need is available everywhere. Okay, and actually, generally speaking, it's very reliable. So you know, in medicine, some tests are notorious to be inaccurate, and you've got to just be a bit cautious with them. But we have very robust tests. So to diagnose PBC, to diagnose it in the first place, you need to have 2 out of 3 things at least, 2 or 3 out of 3. Okay, and those 3 things are firstly a particular liver blood test abnormality, so liver function tests, liver tests, they call different things, blood biochemistry in America, so they have different terms, but these are a set of tests specifically linked to injury to the liver, and there is one of those called the alkaline phosphatase, which is an enzyme protein which is released by the bile duct cells lining the small bile ducts, which are the target for injury in PBC. When they're injured, the levels of alkaline phosphatase go up. Okay, so that's a sign that there is a type of injury in the liver that's to the cell types that are injured in PBC. It does not on its own mean PBC. It means it is one of a group of diseases, one of which is PBC, right? If that makes sense. And just actually it's worth saying that if you, because PBC is very skewed in the population distribution, so typically women, typically people under the age of 50, although we see young people, we see men, the archetypal PBC patient is somebody in their 50s or 60s who's female. If you are in your 50s or above and female, then the commonest cause for a raised alkaline phosphatase in the UK, full stop, is PBC. So it stops being a rare disease in those settings. And I have to say, we see from our GPs who are really good in terms of diagnosing PBC, that message has got across. So they're very good at finding that first abnormality and then following it up, which is normally what happens in practice. So that raised alkaline phosphatase suggests you there or thereabouts. It doesn't, however, make the diagnosis. To make the diagnosis, you need one or both of the other 2 tests. So the first of those is the antibody test, the AMA test or antimitochondrial antibody. It has a number of names. There are other versions of that test. M2, anti-PDC2, various different terms. Actually, the differences between the different tests do not matter. If you are positive for one, you're positive for all of them. And the reality is that your hospital will have the test it has, but it will have some test like that. So best thought of as the PBC antibody, okay? And that's a part of the immune system just mistargeting a little bit. So if that is positive and you've got raised alkaline phosphatase, then that is 98% certain to be PBC, full stop. There are pretty much no false positives. People who've got those tests who don't have PBC, pretty much no false negatives. Those people who don't have those tests and do have PBC, if you know what I mean. There are some other antibodies, so it gets a little bit more complicated. There are some of what are called nuclear antibodies that are present in a lower percentage of PBC patients, and we always talk of them as being equivalent. So you'll hear us talk about or write about PBC antibody, the anti-mitochondrial antibody, or equivalent PBC antibody. That's kind of smaller print stuff, but there are some situations where the AMA is negative, but you've got one of the other antibodies. And if you have that, that makes the diagnosis just as much, all right? The third test is a liver biopsy, okay? And the reason why 2 out of 3 is enough, because the vast majority of people this day and age don't have a liver biopsy to diagnose a disease correctly. So actually, if you've only got 2 out of the 3 tests, it's usually because you haven't done a biopsy. So that doesn't mean you're less certain about the diagnosis. In fact, in many ways, you're more certain, because if you're uncertain, you would have potentially done a biopsy. So don't worry about it. It doesn't create. So one of the things when I see people in the clinic, first and foremost, I say to them, this is certain, right? People hate uncertainty. So where people have got, well, it could be this, could be that, could be the other from various different people. This is, the one thing we know is we know exactly what this is. Based on these tests, it's PBC. We'll get on and manage it, right? So that is sufficient. So raised alkaline phosphatase, an AMA, or an equivalent antibody is what you need for the diagnosis, okay? Now, how bad is it at diagnosis? That's a slightly different question, and it's part of what you do managing forwards. And there are, again, 3 ways you can look at that. The first is the blood tests do give you some idea, but it's not the alkaline phosphatase. It is some of the other blood tests, the bilirubin level, the albumin level, and the platelet count. Those are cells in the blood, which give you an indirect sense of how bad the disease is. So actually, you can tell a lot just from ordinary blood tests. So everyone has those, and you can do that. The second way is biopsy again. And in the bad old days, we used to biopsy people to work out how bad the PBC is. The truth is, you don't need to do that anymore, and you should never really do a biopsy to see if somebody has cirrhosis or not, because the technology is FibroScan or one of the equivalents of it. So that's now pretty much universally available for all liver diseases. It's like ultrasound. It sends a ping out into the liver, measures how much of the ping comes back. It's like sonar in a submarine. And obviously, the more solid your liver is, i.e. more scar tissue, the more ping will return. And FibroScan is really useful. Okay, so you should have that done at the beginning of the disease, not immediately, within the first 6 months, just to work out where you are at the beginning. So the FibroScan tells you how much scarring's happened in the past. The blood tests tell you how active the disease is at the moment, which gives you a backward-looking view and a today view. And from that, you can have a sense of where this goes in the future. Okay, and that's it, basically. There are other tests that, when we're seeing people, there are a number of things that are associated with PBC. And obviously, if fatigue is prominent, there's some other tests we do. But basically, the AMA, the alkaline phosphatase, and then a FibroScan gives you the baseline information about the diagnosis and what you do with it. Okay. And then following people up is, in a way, even simpler, because it boils down to 2 things. One is the liver blood test repeated, and then the other is the FibroScan repeated. You do not need to repeat the AMA. It is it's like flipping a switch. Once you've been AMA positive, you are deemed to be AMA positive. So no need to repeat that. And with the blood tests and the FibroScan, we're looking for change over time and with treatment of those things that we're looking at. And again, the raised alkaline phosphatase level, that's how active the disease is. So that's about future risk. And the FibroScan and the bilirubin, albumin, and platelet count are about how much scarring is there. And that actually, so think of it as a graph with an X and a Y coordinate. You're looking for both of those, right? And that's it. So you come along to see us. We have a chat about PBC. We will usually have had the blood test done by the GP. So that's where I say, absolutely confident this is PBC. Then you'd pop down the corridor, get a FibroScan done, which would tell us exactly where we're going. And we'd leave with you starting ursodeoxycholic acid. We would then tend to phone people at 3 months. Kath, our specialist nurse, who many of you will know, would phone people up at 3 months just to see how they're getting on with the tablets, any problems taking them, tricks and tweaks about, you know, how you take them, just to check in. And then we would see people back at 6 months to repeat their blood tests. Okay. And at that point, we give people some idea of where we're going with this. So the baseline information and then the bloods at 6 months tell us whether you're going to need another therapy over and above ursodeoxycholic acid, in simple terms. And at the moment, technically, we have to wait until a year until we start a second line treatment for people whose bloods haven't settled enough. In truth, we stretch that a little bit. So we're looking from 6 months onwards to add another therapy in here. And think of, you know, if you've got high blood pressure, you go to the doctor, you've got high blood pressure, they start on a tablet, they see you back, see how you're doing, add another tablet in. It's no different to that. It's nothing mysterious or magical about it. Now, symptoms, as everybody knows from listening to me, a big focus of what we do. It's very difficult to know where exactly you're up to with symptoms right at the beginning until you've taken urso. So what we tend to do is say we'll pick up, we'll see where we end up, we'll see where we land with urso, and then we'll ask you again in urso dose calculator.
I was sure I had one of these. I would have one of these in my
So right dose of urso, and then with that, check the blood tests. The reason you've got calculator is because it's weight adjusted, right? You need to set the dose for your weight. So so you would then check the blood tests, see how people are doing, and then you would check symptoms at 3 months and 6 months and get on with treating the symptoms that hadn't been treated with urso. You don't want to change too many things. You know, it's fine to start lots of therapies for lots of different things at the same time until you come back with a side effect, with a rash or something, and you have no idea which of the tablets it is. So generally speaking, doctors will not want to introduce more than one tablet at once because you don't really know if problems arise. Then how frequently do you follow people up? Well, that depends entirely on the degree to which there are problems that need ongoing addressing. Okay. So the default, the baseline is 12 months. So if you've got no symptoms and your blood tests are normal on treatment, you'll come back and see us every year. And we'd repeat your FibroScan every year, usually ultrasound scan every couple of years, bone density at the beginning, and then, you know, every few years. So for people who are doing very well, it's an annual thing. We would see people more frequently if any of those things weren't true. So if people have got complex symptoms and we're working on improving those, we'd see people more frequently. If they had more severe disease, we'd see them more frequently. If we are watching them for need for second line therapy, we would see them more frequently. And so it's very much, there isn't a hard and fast rule, and it's a balance between burdening people and keeping an eye on it. But we have in our system the ability to do phone follow-ups, you know, in between the appointments. So people can contact Kath and speak to her. And so that, in a sense, you know, we schedule them when we want the bloods or where we anticipate a treatment change. And otherwise, you know, I think our people like, you know, the ability to have a mixture of face-to-face visits and phone calls, because we cover a large area of the country geographically. People could spend 4 hours coming to see us and 4 hours back, and you know, so I think it's a common sense thing. I think what we found after COVID is the thing people didn't like is being told it's phone conversations, given the option if they wanted to. And we tell people you can change in the morning. So if we book you in for the same appointment, let us know in the morning if you want to do it on the phone, and people do, you know, and so it works pretty well. And that's it. So AMA liver blood tests plus a FibroScan at baseline, and then liver blood tests plus repeat FibroScan during follow-up and in response to treatment. Do you ever need a biopsy in 2025? Yes, you do. A minority of people. The first is clearly if you don't have an antibody and you just have a raised alkaline phosphatase, there are about 20 different conditions it could be. So unless you've got the PBC test, you can't diagnose PBC, because all you can achieve is 1 out of 3, and it's the least specific one. So AMA negative PBC, which is pretty rare but does exist, needs a biopsy. Another one is if you've got 2 very obvious disease processes. So if you've got the PBC antibody and you've got a raised alkaline phosphatase, but also you've got a lot of fat in the liver on ultrasound, it's difficult to know which is the actual process. So some people biopsy for that. I often don't, for the simple reason that ursodeoxycholic acid is an effective therapy for both of them. So just crack on and treat it and then see what the treatment does. So don't, in a way, if you've got fat in the liver, you want to try and lose some of the fat through diet and exercise anyway. And actually the treatment, a reasonable first treatment is the same. And actually it looks like some of the second line therapies for PBC also work for fatty liver. So we tend not to do it. Just occasionally you'll have, a really unusual combination. Somebody who had, I've come across somebody who had both PBC and a family history of a thing called hemochromatosis, which is a iron deposition disease. Well, you can't tell which of those is it one, the other, or both. And so in that situation, you might do a biopsy, but it's a minority of people. Occasionally, if we're getting absolutely nowhere with therapy, we're giving standard therapies and we're seeing no response, it always raises the possibility that there is another disease process that we're not recognizing. So that might be a reason. But my rule of thumb for a biopsy is I've got to be able to explain to you as the patient why that biopsy will change the management I give you. And I've given you some examples of that. Otherwise, I wouldn't do it. So no hard and fast rule for how often you follow it up. It should be based on need and balance. But the really important thing is that somebody is following you up and somebody is looking at your tests and interpreting them. And amongst the people looking at the tests and interpreting them should, of course, be you, because you've got most vested in it. And that colleagues, Mo in particular at the foundation, spend an awful lot of time working with people on what your tests mean. I have a feeling a leaflet's going to be waved in a second.
It is, yes, I'm getting ready for that. Yep.
It's really, really important about...
So we touched on the Ursus calculator. Now, these are all available either in paper copy from the office, or you can access them and download them on the website, or view them on the website in digital form as well. So your Ursus calculator that helps you see what dose you should be on. We've also, just point of interest on the back there, that's patient organisations from all across the world that are on that part branded, which is just amazing. It's the same one that's used throughout. And then our most recent ones, which is the patient guide to appointment preparation, which you can do in terms of getting ready for your appointment. And then also really just covering everything that you covered there, Professor, is the discussing PBC with your clinician. And that and it's got details of the care bundle and questions and things to be aware of and ask about. So one of the things that we're hoping to cover at our conference this year actually is giving a bit more guidance around reading your tests and just understanding them on a bit more of a level, so that, because we're definitely seeing that our patients are becoming more informed in terms of the access they've got to information. So we felt that would be a good addition to add on as well.
I think these are all fantastic things, and I really think the one about the questions you should ask, I think as a leaflet, that is fantastic, because and hopefully the more people, so if you use that with your consultation, and you will both get better care yourself, but you will also help other people get better care. Because after a while, if enough people use it, the clinicians will recognize the questions that are going to be asked and will not need prompting. Okay. So in a way, these are the questions these are the issues we raise in our consultations, but everybody should do it. And, anybody who's, owned a spaniel knows that unless you train a spaniel, nothing constructive ever happens. And it's the same with doctors. I can say that. I am a doctor. I can say that. Is they need training. Otherwise, they run around and piddle on the carpet. I mean, no, they don't. But they need training, and you can help train them, right? We
have had some excellent feedback on the appointment guide for the appointment preparation and the discussing PBC, both from clinicians and also from patients taking them in as well. So that's been really well received.
Genuinely, I think doctors come in lots of different qualities, if you like, but I genuinely believe most people don't wake up in the morning wanting to do it badly. I don't think there are one or two rogue ones out there, I think, but most people don't want to do it badly. They just don't know how to do it well. And the more we in a non-confrontational way, help them to do it well, the better for everyone. They're happier, you're happier, and it just, I don't think it's deliberate. I think it's inadvertent. I think some people have a closed mind. I mean, we do quote some unusual people on these sessions, but I'm going to quote Donald Rumsfeld, and it is Donald Rumsfeld's known knowns, known unknowns, and unknown unknowns. And so, the known knowns are people like me who talk about this sort of stuff all the time. The known unknowns are the people who don't know the answer, but they know they need to know the answer and seek it out. Okay, and they're fine because they're the ones who will get better and engaging, and they're getting more and more involved in all of this and seeing much more of it. And then the problem is the unknown unknowns, the people who don't know what they don't know and don't care to find out about it. And they're the most difficult ones to reach because they won't come to educational stuff. I mean, I just thought I'd mention the European Liver meeting in Amsterdam, people from around the world coming together. And the number one topic of conversation, I mean, you will have heard this, Mo, from colleagues, the number one topic of conversation was PBC, okay? Yeah. Number one topic of conversation. There were more companies developing drugs in PBC than in any other disease area. And there were thousands of people at the various different sessions about PBC. Somebody said to me, you said to me, because, we've been fighting this fight for a long time now. And, sometimes in the past you'd have, 2 people at a meeting. And yet we pushed on and pushed on and pushed on. And somebody said to me, you must be very pleased with this. And I said, I look at this with disbelief. After all of these years, people finally accept it. And the number one topic of conversation about the number one topic, which was PBC, was symptoms. So that's doubly pinch yourself time. Yeah. Because so I think at that meeting will have been an awful lot of people who are not PBC people going to lots of sessions, learning about it. And that's the battle, is to get people to engage with it all. So I think it was very heartening to see how much interest there was around PBC. And the story I always tell is that you go to any medical congress, there'll always be some big banner above the door, okay, that drug companies pay for, because it's people walk in through the front door and look at it, right? And for as long as I've been going to meetings, it's fatty liver disease or viral hepatitis, okay? Be one of those treatments. This time you walked into the meeting and it was about itch in PBC, okay? And we really have won the battle if that's the first and that's the dominant thing you see, is how on earth do you treat itch better? I mean, you couldn't make it up. And that's the reward for all of us, having a very clear message that we repeat again and again and again and again, and we will continue to do it until you get it. I think people were starting to get it. And actually, one of the things that was talked about an awful lot was some of the data that I've talked about before, which is the sheer impact of severe itch, where there's some very good research on it done by GSK. I was involved in it, other people were, just looking at the sheer impact of severe itch and how it affects people's lives. I think that's really important. I think there is still a clinician group who say, oh, what's a bit of itch, what's a bit of tiredness, I get tired at the weekend, so I think we are winning the fight. Okay. Yeah, we are. It is amazing to see. Right, I'm going to move on to our other questions here. Thanks for doing that for me. I'll make a little special video for us and I'll be able to upload that separately as well. So any questions, you can put them in the chat. Just any hospital that doesn't have FibroScan, okay, and it's different in different parts of the world, okay, so I'm talking principally about the UK. So it's more a European thing than a North American thing. So it's very much a European technology. And it should be available in the clinic where you are seen. It shouldn't be something you have to book in 6 weeks in advance for an appointment. It should be a real-time test, like getting your blood done, okay? Mm-hmm. If your hospital doesn't have FibroScan, I think it's reasonable to ask your clinician why not in 2025, okay? Because it's standard technology for every liver disease, and it's very powerful. It's not infallible. You have to put it into context. But it's a really important step forward. It's painless to you. It's just like having an ultrasound scan. And the really important thing for hospitals to realize is that once you've bought the machine, it's free, essentially. So you have to put a cover over the probe, and that's it. It's about £1. And therefore, it's a free test. And we would do thousands in a year. And so if you do thousands in a year and the piece of equipment, costs 10,000 quid or something, it's actually a really cheap test. So actually, once you have it, you use it all the time and come to rely on it. And of course, if you are somebody with a very low FibroScan value and your blood tests are fine, if you've got somebody who has a normal alkaline phosphatase on treatment and you don't have a FibroScan, you still don't know whether they maybe had cirrhosis that developed before they, even, were diagnosed. So there's still an element of uncertainty. And so you would deal with that by seeing those people more frequently. You would still just be not entirely confident. But once you've got a normal FibroScan, there's no existing scarring. So that person is onto a once-a-year follow-up. So, and given that a consultation, an outpatient's appointment costs the NHS around £200, to do a FibroScan at £10 to avoid an unnecessary hospital visit at £200, I can do the maths on that one. So it really is something they should have. Get the nurses trained up to do it. They very much enjoy doing it. Kath builds it into her conversation. She does them, not me, because you need to have people who do lots of them, and she builds it in. And she finds actually it's a strangely good time to talk to people about things, and it's where she chats to people about life. And she said things have cropped up whilst having that bit of a chat that hadn't cropped up in consultations. So just build it into your ordinary consultation thing, and it is very powerful.
We've actually got, I'm going to, just something that you touched on there. There's a question that we have that's kind of around that. So it's a wee bit of a long question, but hopefully you'll see where I'm getting to. So patient who was diagnosed with PBC 13 years ago, confirmed stage 1 to 2 by liver biopsy, had no symptoms, was found during some routine blood work, started on Urso, was a responder. Their labs are now normal, they've got no symptoms, and the FibroScans over the years have gotten better and better, and this year the score was 4.3. But there is some evidence that now within an elastography MRI that they've got stiffness of the liver with stage 1 to 2 again, but it mentioned nodularity and possible cirrhosis. Because you touched there about if there was historical cirrhosis, and then the FibroScan scores better. So I think what the general feel is, I don't understand how all my FibroScans through the years and now my MRI all show low fibrosis. My labs are normal, yet I'm still having someone say I have nodularity and say there is some cirrhosis. A bit confused.
Yeah, so the really good question. Okay, so you can do too many tests. Okay, and the reason why that's a problem is that all tests have an error rate to them. Okay, so and that's because we're all built differently. So, I mean, FibroScan doesn't measure the actual amount of fibrosis in your liver. What I've described is it measures how reflective your liver is, right? So, same thing as, if you want to know if a train, if people working on the railway lines want to know if a train's coming, they squat their head, put their head on the line, and because you'll hear it much better because solid conducts sound better than air, right? So it doesn't tell you whether you've got fibrosis. It tells you whether your liver is stiff, and liver stiffness is associated with fibrosis. So it's not infallible. That's the reason that I said, right? Anyone who tells you that, anyone who sees a lot of FibroScans will tell you get rogue results as well. Okay, so you will have, I've seen somebody who's gone 4, 4, 4, 4, 30, right? And one of my colleagues learned a very important lesson, which is that if you go 4, 4, 4, 4, 30, the 30 is almost certainly an error, okay, because it does not fit with the trend pattern and the time of change of PBC. PBC didn't change from 4 to 30 in a year, right? It changes from 4 to 6 to 8 to 10 to 12 in a year. That's the bad pattern, right? Now, what you do in that situation is you simply repeat the test on a different day with a different person doing it. Anybody who's had a FibroScan will know that it's not something like a CT scan where you have a hard image. So you do that, you have a look at it all, but then somebody can come back to it and have a look at it again. It's like watching somebody walk down the road. You have a recollection of it, you have an interpretation of it, but nobody can assess that because the person's not walking down the road anymore, right? So you need to build that into what you do. So you therefore repeat it and look for trends. And the reason why my colleagues learned the hard way is because they biopsied somebody who had a big bleed after the biopsy, and the biopsy in fact showed that it was completely normal liver other than very mild PBC. Okay, and the FibroScan was 4 when it was repeated. I can't explain why that was. Might be they got a bit of bone into it, so if you overlie the bone, that's pretty dense, or you've eaten a very large breakfast or something like, I don't know, but it just, you don't take these things as gospel. Okay, now MR elastography is a toy. Okay, everyone loves it. It's a new whizzy way of doing things. It's not widely available, and it combines an MR scan. MR scans are not, I had plenty of my knee done. They're not the sort of thing people necessarily want to have done. And it gives you lots of information, but lots of information can sow lots of red herrings. Now, virtually every patient that has ever been sent to me with PBC who's had an ultrasound scan is told that they have nodular irregularity in their liver query cirrhosis. Okay, virtually everyone. And it includes all the people who don't have cirrhosis. So we utterly discount that, okay? For the reason being is that they're interpreting the diagnosis of liver disease, and people have a residual recollection that PBC stands for primary biliary cirrhosis. So what they're doing is they're interpreting the clinical information, okay? And they're putting 2 and 2 together and making 19, okay? So I can tell you when somebody comes along with irregularity of the liver query cirrhosis of PBC, I discount it completely. That is normal in PBC patients. And that's what they're describing with the MR, okay? The imaging side of it. Elastography, as you say, is a new technology. It's not widely available. There's a learning curve with it, okay? At the end of the day, your trend line is the key one. So if you've had 4, 4, 4, 4, 4, then actually the rogue result is the MR elastography, and it's got a health warning that I've attached to it. So if I saw somebody like that, I would say, let's just repeat the FibroScan, and I would believe that, okay? Now, there are things on a MR scan that can tell you whether they've got cirrhosis or not. So you can have a look at whether you've got varices on a scan like that. You can look at spleen size. You can look at that. So those are reliable if they're there, but not an irregular outline of the liver. So it's a different technology done on a different day, which is a less widely used technology. We've had a series of FibroScans, all of which show the same thing. Then believe me, unless it's 20 years between those things or 10 years, it ain't gone from 4 to cirrhosis in a year, okay? So there is what we call in the trade a rabbit off with that, and you just got to repeat the thing, which is the one that's been done all the time. It's just, if you had an electricity meter in your house and you've paid the same amount for your electricity for the last 10 years, and they put a new meter in and all of a sudden they charge you 10 times as much, your first response is going, gosh, I didn't realize I've used so much electricity. They would say there's something wrong with the new way of doing it. Yeah. And it's just the same. So that's why doctors, this is here I am making a case for doctors, which is why we won't be replaced by AI for quite a long time, because AI doesn't interpret, okay? It simply accepts information and takes it at face value, whereas we know that the answer is never black or white. It's always grey in one shade or another, and actually that's what's factored in, okay? So just be aware of that.
Great, thank you.
And people love FibroScan's boring now. It's an ultrasound scan and it only takes 5 minutes, but MR elastography is a man test with a big machine that goes ping. And people love new technology, but actually you only need new technology if older, simpler technology is not giving you the answer. And so people often say, oh, we should use MR elastography. Why? Actually, why, when you have a 6-month waiting list to do it, and there's a machine that we've used for years and which is incredibly useful in practice, sitting in the room next door, and we can do it in 5 minutes and give you the answer. Why would you want to do that? Other than you like new toys.
Just touching as well, you mentioned the name change there. 10 years this year since the name change.
Is that right?
Yes, 10 years. Right, patient diagnosed 1 year ago. FibroScan was 5.3 at the time, started 900 milligrams of Urso.
So just going back to the last lady, okay? Presume a lady. I do apologise if not, right? So normal biochemistry, okay, on Urso, brilliant. So there's no activity of the disease. FibroScan
in the room?
Oh,
he's back. I was just going to say, Professor Jones has frozen for me. Is it the same for everyone? But you're back. You're back. Right, we got to the point where we were just going to recap the previous one. The lady, you were going to recap the blood test.
Oh, you did. Oh, you did lose me. Okay.
I did. Yes.
What I was saying is that FibroScan of 4, so blood tests that are normal, perfect response to URSA, no activity in terms of damage to the liver going on now. That's brilliant. FibroScan of 4 indicates no fibrosis at all. Okay, so that is normal. Okay, your liver, you never get 0 at the FibroScan because your liver would be gas at that point. And believe me, you don't want your liver to be gas. So that's as low as it ever gets. So with that, that's a perfect response to treatment. And that's brilliant. You should be being absolutely reassured by your clinicians and told all of that, and we would see people every year with that just to check everything's okay. What you shouldn't do is find another random test to do, to check the other tests, unless there's a reason to do it. Great,
thank you. So next question, patient diagnosed a year ago, FibroScan was 5.3 at the time, started 900 milligrams urso, but couldn't tolerate urso due to the side effects. Yeah. In January this year, because of that, they reduced the urso to 300 milligrams a day while they were waiting elafibranor. At that time, the FibroScan was 5.9, so all good. Having been on urso 300 milligrams for a day for the last 3 months and had another FibroScan's now 3.6. So liver nurse is thinking, whatever I'm doing, maintain it because that's a good result. The questions are around, could the result of 3.6 just be a fluke? The difference is that, well, due to other chronic conditions, the patient was off work, so was getting good sleep, didn't have any stress. And the question she's asking herself is now, because she still hadn't started elafibranor at that point, should she maintain on 300 milligrams of urso daily, or should she think about starting elafibranor?
Really good question. So remember what I said about FibroScan is theme of the day, isn't it?
Yes. So, yeah.
Remember what I said about FibroScan does not measure fibrosis; it measures how pingy the liver is. Okay, and of course, most reflexivity of the liver is to do with fibrosis, but not all of it. Okay, and if your liver is swollen because you've got active PBC, that can also put the FibroScan value up. And that's why the very first FibroScan value you have, just be a little bit cautious about it, because if the liver is stretched and very tight in the capsule, maybe you've got a bit of right upper quadrant pain, a bit of pain over the liver is always a giveaway. That's because the liver is the capsule of the liver that lines is a bit stretched. It's all a bit under pressure. And that will always improve with urso and other treatments. So what I suspect there is that actually the 5.9 was a little bit artificially elevated because it was untreated PBC at that point, and actually you've now had treatment. And you've kind of gone back to where it actually is, which is really good. Okay. Now, a dose of 13 to 15 milligrams per kilogram. If only there was a simple way to be able to calculate that. Mo, have you come across a simple way to calculate the right urso dose? Oh, yes, you have. Right. It is important to do that. On average, that's the right thing to do. Okay. So if you look at 1,000 people, the largest number of people have the best response if you do it to 13 to 15 milligrams. However, you are one in that 1,000, and that does not extrapolate all down to individuals. So individuals need a certain dose that's right one for them. And of course, this idea that, nothing works unless it's the right dose. Of course, we started giving people 300, 500, 600 milligrams a day of urso, and lots of people did really well with it. There's still plenty of people out there who are only on tiny doses of urso with normal tests. So whatever the dose is that's right for you, the dose is right for you. Okay. So if you have a FibroScan of 3.9, that tells you how long this has been going on, and that's good. It does no fibrosis. The key thing will be the blood tests. Okay, so if the blood tests, and I don't know if you mentioned those, but if the blood tests have returned to normal with that FibroScan, then actually whatever you're doing is the right thing because it's clearly working. Okay, if the blood tests are abnormal, then the problem is that you haven't got existing fibrosis, but if the disease is active, then that could develop over time. Now, elafibranor, good drug. However, it's not been used for very long periods of time. So there are still questions about it. There's no a priori concern, but, in a sense, a drug you've used for 30 years, you know much more about it than a drug that's been on the market for a year or so. So there's an element of the voyage into the unknown with it. So I would only really go to elafibranor if there was a good reason to. And that reason will be you haven't responded enough to urso, or the other reason would be if you are intolerant of urso and need therapy, okay? But actually, if the blood tests happen to be normal and the FibroScan is normal, then actually you've had an adequate response to urso. And as long as it isn't causing you problems, I would continue on the low dose of urso and watch it, okay? If you're still struggling with the 300 of urso or your liver blood tests are abnormal, then I would go on to elafibranor. So I would actually, I think at the end of the day, 300 milligrams is, quotes, underdosing. However, it could well be the right dose for you. And
the patient does mention that further bloods were taken, but no results at the time of submitting the question. So
yes,
given the information you've given
that's
and then
my answer.
The blood results, they'll probably be able to make a better decision on that now.
Yeah, if the blood tests are normal and you're able to take the 300, then fine. You're somebody who responds to a low dose of urso. If either of those is not true, I think elafibranor is a good choice.
Great, thank you. I'm just going to, we've had a couple of questions in the room here that are probably ones that we could take off. So we've got, can rivastatin 5 milligram once weekly affect liver tests and kidney tests and creatine tests?
Yeah, so there's a statin used for cholesterol lowering, used for heart disease prevention. 5 milligrams a day is a very low dose, which once weekly, very, very low dose, those drugs can affect liver tests, can affect kidney tests. Like every single drug known to man, there are benefits and there are risks, and it's a balance between those benefits and risks, okay? And with a statin, the key thing is why are you taking it, okay? Now, as I say always to people, there are kind of three reasons why somebody would take a statin, okay? So the first is that they've got really high cholesterol. And these are why they were invented. And this is familial hypercholesterolemia. And these were families where people were dying in their 20s and 30s from heart disease because they had a genetic abnormality that meant the cholesterol was ridiculously high. And statins were absolutely mandatory in that situation and life-saving, okay? The second reason is in people who've had a heart attack or have had a stroke or, a process like that. In which case you need to do, because you're clearly at risk because it's happened once, you need to do something to reduce the risk moving forward. So that's a very good reason to use a statin in those situations. It's not mandatory like it is for familial high cholesterol, but it's a really good idea, okay? And then the third is actually the group that's most people in our society. And that's where you've gone to the doctor, they've plugged your numbers into a computer, come up with a risk score, and they've given you a 10-year heart disease risk score of whatever. And if you're above a certain age and above a certain value, they suggest you take statins. And that's much more nuanced, okay? And that's where the benefits and risks being balanced comes into it. If you've got familial hypercholesterolemia, there is no risk really with these drugs is greater than the risk of the disease. But if you're dealing with a really marginal, most people who've had a heart attack don't have another one. Most people who've had angina don't have a heart attack, So it is very, very nuanced. In those situations, you need to go back to why you're on those drugs. And that's particularly a caveat with PBC, because PBC puts your cholesterol up in a non-harmful way. And so most people on statins with PBC are having a number that happens to be associated with PBC, but which is not associated with risk treated to bring the number down. Makes the doctor feel better, doesn't really do that much for you, okay? So in those situations, so would I trade off liver blood test abnormality and kidney tests for statin unless I'd had a heart attack or I had familial hypercholesterolemia? No, is a short answer. But I would revisit why I'm taking it, revisit what those abnormalities are, and then I would seriously consider it. And of course, how do you know the drug has caused these things? That's always a problem we see in liver medicine where, things happen, blood tests become abnormal, they fluctuate a little bit. If you stop the treatment and those get better, then that's really usually a good piece of evidence. And of course, with statins, if you're worried about high blood pressure tablets, you decide to stop taking them, that's a really bad move because your blood pressure can shoot right up. You can have a stroke tonight, okay? But statins are not like that. It's 3, 6, 9 months, okay? So if there's any doubt, you come off statins for a while and see whether the problem's resolved. If they don't resolve, it's not the statin. and you're back to a different situation. So it's one of these drugs. Don't be scared of, finding out by having a holiday off it. You'll soon work out whether the problem is linked. But whatever people tell you, statins are not mandatory other than in very specific groups of people. On average, it's back to our old friend, the 1,000 people. Amongst that 1,000 people, on average, there's a group of people where statins will be beneficial. But that will include people who do worse on statins as well as people who do better. So it's not black and white, okay?
I've noticed another FibroScan. I'd just like to pick that up because we've been chatting about that quite a lot today. Patient diagnosed 11 years. Bloods are all normal except DLP, which is 158. Yeah. Only ever been on Urso and was scanned in the beginning, but not for 10 years. Yeah. Did a FibroScan last year, 21.4 kp. Okay. Since an ultrasound and confirmed mild cirrhosis. Is it normal if bloods are okay that you then progress onto cirrhosis?
So, sorry, what was the endoscopy?
The FibroScan. It was 21.4 kp.
It just cut off, so a bit after the FibroScan of 21 and a bit.
Since had an ultrasound which confirmed mild cirrhosis, is it normal if bloods are okay to progress into cirrhosis?
Okay, so first thing to say is, are we sure about those? So ultrasound scans suggest mild cirrhosis. That's back to irregular outline query cause, okay?
Right,
so,
okay.
I don't want to see that. And because remember, when you go for an ultrasound scan, people put the clinical story on the form. So if somebody puts FibroScan 21 PBC, and then the radiologist remembers that's primary biliary cirrhosis, and the FibroScan suggests cirrhosis, what are they going to find, right? So now, the first thing I would want to look at that scan report and see, is the spleen enlarged? Is there evidence of portal hypertension? Okay, because those are the harder signs on an ultrasound scan, right? Mm-hmm. I would also, if you have had blood tests at that sort of level for a long period of time and have progressed to cirrhosis, so anything above 17 is suggestive of cirrhosis, okay? That's pretty unlucky, okay? I would have to say that's unlucky. It may be that that's the effect of the bloods being, quotes, good but not normal, which is something that we talk about all the time, is that 150 something is not normal. It's in the response range, but I think there is a growing sense that we probably need to tighten up on that, okay? So what I would do in that situation is look at the ultrasound scan, look at the platelet counts, look if there's any sort of supporting evidence that would go with it, and then I would probably want to get the FibroScan repeated, because that doesn't quite ring true, and you don't want to go. And what I said about the person who'd had a FibroScan done, after lots of ones that were normal, and it was at that exactly that level, had a biopsy, found to have cirrhosis, found to have a normal liver, actually had a bleed from the biopsy. So I would want to just check that, because that doesn't quite add up to me, and so I think that would be a very wise thing to do. If the FibroScan shows exactly the same thing, and I've got a lady that I see who I said exactly this to, and we repeated the FibroScan and we did some other imaging, and she had cirrhosis with normal liver function tests, okay? So it can happen, and it doesn't feel fair, but it, sometimes it's the nature of the beast. So the first thing, so in that situation, what do you do? Well, first off, I'd want that alkaline phosphatase normal, okay? So the first and number one priority is to protect the liver, okay? So it doesn't get any worse. So although you're in a response range, you'd want to get that normal. So, use Urso or bezafibrate or elafibranor. Those are drugs you can certainly use in people with early cirrhosis, right? So I think it becomes even more important to control it completely, whilst, kicking the furniture, because it's not fair. And it isn't fair. Kick the furniture, don't kick the dog or the cat, because that's not nice. So I said I'd go kick the cat, and somebody complained once that I was advocating cat kitting. Now, anyone who knows me and the number of cat photos I've got on my phone knows that's not true, right? So after that, you need then to go into risk management mode as well. So two priorities now: control the disease as much as you possibly can, normal liver blood tests, and seeing whether you've got any complications of cirrhosis, because that will give you an idea of what we can do to reduce risk, but also some idea of whether this is problematic. okay? And actually, it's the presence of varices that matter. So much as you will hate me for saying this, you need an endoscopy to look for varices, okay? That's really important. And the chances are, I bet you anything, okay, that you won't have varices, right? Because this just doesn't quite add up to me. And I bet you, based on experience, you do the endoscopy, you don't have varices. So that tells you, at worst, it's non-portal hypertension, you know, early cirrhosis. Now, in that situation, remember, your survival is the same as anybody else with PBC, okay? It is only if you have varices that risk comes in. So the third thing, so the first thing to do is just double check all of this. The second is to fully control the disease. And then the third is actually not to panic and to realize that as long as you get the basics right, people can be absolutely fine with this over long periods of time. So don't panic with it. It might be worth having a chat with Mo or somebody at the foundation about the specifics of it, just the specific questions to ask, because it's important for you to know. But our experience is most people who suddenly seem to develop cirrhosis out of the blue don't have cirrhosis, okay? But I think it might, would you agree with that, Mo? That might be one to have a little chat about.
Yeah, I've taken a wee note actually just to make sure the patient who submitted this question is aware it's in this session so that they can have a look, and then
yes, I think so. And just there's a little bits of follow-up information, but FibroScan is one of those tests that you will get rogue results, and when you get rogue results, don't assume that they're correct. If it doesn't fit, repeat it on a different day with a different person doing it, and if it's the same answer, it's the answer. But if it's changed, it hasn't suddenly fluctuated. It's just some tests, a hemoglobin value, right, is as accurate as anything you can imagine. Do it day in, day out, you'll get exactly the same result. But a potassium value in your blood can fluctuate all over the place. So, a potassium value above 5, that's dangerous to your heart, and you get it in renal failure. So I've had, people with the potassium come back as 9. And their junior doctor's been on the phone to the renal unit to organise dialysis, things like that. But red cells, when they break, when you take them through a syringe, release potassium. So any doctor who's been around more than about 30 seconds knows if you get a potassium result, which is totally implausible, you just recheck it, okay? Mm-hmm. And, this, again, is why we won't be replaced by AI. I mean, you might think that me being replaced by AI and therefore not droning on quite so much is a good idea, but you do have to contextualize everything in this game.
And actually, that is what I really like about these sessions. We get a question that seems to be quite specific, but we generalize it, and it brings in information that can help lots of people that are watching. So I think that's
if you remember anything from today, other than don't ring into my sessions, if you remember anything, is that PBC does not change quickly, okay? PBC changes either not at all or very slowly. It improves relatively slowly with treatment. If you don't treat it, it will only ever deteriorate very slowly. And most people, it stays the same. So if you have some tests, the only exception to that is very advanced disease. If you're heading towards a transplant, it's a slightly different thing. But for most people, 99% of people with PBC, this changes slowly. I tell this to people in the clinic, do not worry about going to the clinic. There will not be any bad news, because that's not how PBC behaves. It's trends over time. So if you seem to have some radical acute change, then the first question is that real or not? Okay, and don't panic about it.
And that's very reassuring. I'd just like to take that question that's in the chat before we finish up. Just a question around vitamin D tablets. Good for a 75-year-old with PBC.
Yes, is the short answer. So pretty much everybody in the UK is short of vitamin D. It's to do with the fact that we never get any sun. Just for those people in Scotland, the sun is an orange thing visible in the sky in the south of England.
It's out today. Yeah. There's a blue sky today, I'll tell you.
Basically, we don't get enough sun, right? Because of the northern climate. We then, if we do go out in the sun, we put factor 50 sunblock on, and basically you need sunlight to make vitamin D. And you add a little bit of PBC to that, because you can absorb it from the diet, except it's less good if you've got PBC. So basically, we don't ever measure vitamin D in the clinic because everybody's vitamin D is low, okay? So that's why taking vitamin D is useful. If my wife was here, she would go on about this the next hour. She leaves bottles of vitamin D all around the house on the off chance that we'll take them. So yes, it's a good idea. Okay, good for your bones, good for sleep and the immune system, just good. You can't go wrong taking it. It's almost impossible to take too much vitamin D. And remember the idea that vitamin D toxicity is the reason why you shouldn't eat polar bear liver. So eating polar bear liver is dangerous for you. Now, I'd imagined it was killing the polar bear in the first place, but it isn't. It's toxic, and it was always thought to be vitamin D, which accumulates in the liver of polar bears from all the fish they eat. In fact, it's vitamin A. And if anybody wins Who Wants to Be a Millionaire, and that's the £1 million question, I want to share.
I want to share, yeah. Just quickly before you go, just that question there about the FibroScan. When you're having your FibroScan, should it be held on your liver or moved around your liver? Just while we're doing nothing, FibroScan.
They move around, okay? So they'll do it in a number of different sites. And what they're doing is trying to avoid the bone, and they're trying, it can't cover the whole liver, okay? It can't cover the whole liver. And that's one of its weaknesses. That's said to be one of the reasons why MR elastography is good, because it looks at more of the liver, but it's a more uncertain test. So they will do it in different places, and they will often move it to try and get a better signal. And what they're doing is they're doing multiple shots, if you like, and they're looking for them to be reproducible. So they're not just doing a value, they're doing 20 values, and there are certain thresholds for how those 20 values show you the same thing, and that's part of the validation for it. And the more experienced the person doing it is, the more accurate it will be. So there's nothing to be, they're not looking for something, they're not looking, like they might on an ultrasound scan. They've seen something, they want to see it from an angle. They're looking for a clean shot, if you like.
Brilliant. Thank you so much. We've had lots of comments coming in there about being another great session. And I know I learn something every week as well, which is just fab. So thank you so much for your time. Thanks to everyone.
And I think I'm booked in.
You go, that's fine. I'll finish up. Take care. See you soon.
All right. See you later. Bye, everyone.
See you later. So if you've submitted a question and we didn't get to it, I will hold it over for the next session. If you need a quicker response to any of your queries, please know that we're here on the helpline, and we're here if you need us. And please just reach out if we can be of any help. And I look forward to seeing you on another session.